Hi, everyone. I'm Saad Omer. I'm the director of the Yale Institute for Global Health, as many of you are likely to know. I am delighted to welcome you to the first hybrid event that we have started doing, in this new academic year that the Yale Institute for Global Health has started doing. We are delighted to be here at the Yale School of Public Health, and we welcome those who are joining us online. I know that a bunch of you have been joining us online over the last few years. So in addition to the Yale Institute for Global Health, today's event is co-sponsored by the Walker Fund at the MacMillan Center at Yale. The COVID-19 pandemic has highlighted the critical need to better prepare for future pandemics. And this is not going to be the last major infectious disease-related event. We have already seen monkeypox, public health emergencies pop up with some frequency, and there are estimates that unfortunately the frequency of these kinds of events is likely to increase. During this event, our panelists will present and discuss several themes and several elements for an effective pandemic response. And we have three very prominent, thoughtful panelists and speakers for today's event. And before moving to their presentation and our discussion, I'm going to introduce them together, give you a little bit of their background, and then we're going to go to their respective presentations and then the question and answer session, where I'll start with questions and then we'll take audience questions both on-site and online. So Dr. Jennifer Nuzzo is the inaugural director of the Pandemic Center at Brown University School of Public Health. Before I became the inaugural director of YGH, I used to imagine that people just come into their centers on day one and cut a ribbon or something. That's how they become inaugural directors. I have no such illusion anymore. But the center has already done a lot of significant things and is becoming fairly prominent in the discourse around public health preparedness. She's also a senior fellow for global health at the Council on Foreign Relations. She's an epidemiologist by training. Her work focuses on global health security, public health preparedness and response, and I guess if I can sort of share my bias, most importantly on health systems resilience. So we are public health people. We go for primary prevention if possible. So creating a resilient health system is in that category. Dr. Nuzzo regularly engages with the media, both electronic and print media, to educate and inform about emerging health security trends. Dr. Wilmot James is a former member of parliament in South Africa and ranking opposition spokesperson on health. Currently, he's a senior researcher scholar at the Institute for Social and Economic Research and Policy at Columbia University, just a small train ride away, where he leads the Center for Pandemic Research. He conducts research on pandemic response and biosecurity, and convenes with some frequency high-level meetings on planetary threats. He's also an honorary professor of global health at University of Witwatersrand in Johannesburg. Beth Cameron is a professor of practice of health services, policy and practice at Brown University, and Dr. Cameron is a national expert in health security, pandemic preparedness, biosecurity, biodefense, and bioterrorism, and she has worked at the highest level of the government, including serving as the special assistant to the president and senior director for global health security and biodefense for the White House National Security Council. She also serves as a senior advisor to the U.S. Agency for International Development, USAID, but here is not representing any government or government agency. She is here as a professor and as in her own personal capacity as a key opinion leader in this area. So we are honored to have all three of you here today. So we for today's event, each of our panelists will do a short presentation followed by 1 or 2 questions. And so after the presentation is complete, so actually I would suggest that you restrict those questions to clarifying questions, and any substantive questions we will get to them after the initial presentation. So if you want any clarification, feel free to sort of follow up. But if you have more substantive questions, we'll do that in the panel. And obviously, for those on Zoom, will also have an opportunity to ask questions. With that, I would like to welcome Dr. Nuzzo to deliver the presentation.
Thank you so much. Thanks for that kind introduction, and thanks for the invitation. It's really such a pleasure to be here to learn more about the work of people I admire so greatly, like yourself, Saad, and your colleagues, but also to meet with students. We had great conversations today. So if we advance to the next slide, we're going to spend today talking about how to better prepare for these sorts of events. And that's a huge topic, but I'm just going to take 2 small pieces, which is thinking about surveillance and the role of surveillance and how we can improve it, as well as the workforce. The workforce to support surveillance, but to some extent the broader public health workforce. Prior to coming to Brown, while I was at Johns Hopkins, I had the privilege to be part of the team behind the Johns Hopkins coronavirus map, which was started by my Hopkins colleague, Dr. Lauren Gardner. And I'm showing a screenshot of the map from actually Friday of last week. So these are somewhat up-to-date numbers. But I'm showing this really as a bit of an allegory for how we should think about improving surveillance and data. The first thing I want to point out is that this map was created by people outside of government because there was nothing like it, and there was very much a need to stay up to date with the case numbers, where they were occurring, and to analyze those case numbers in the context of other factors. So that was clearly a need that, in my mind, there is now at least a mechanism to address with the creation of the WHO Pandemic Hub, but still I think a long way to go to make sure that we have in future events something like this. This was an extraordinary resource-intensive effort, very expensive effort. I'm very proud of the work that it did. But it also, I think, represented just a small piece of the challenge of fixing surveillance for these sorts of global emergencies. And part of why we need to fix this is not just to get the up-to-date picture, the dashboard that tells us what's going on now, and to help us analyze these numbers so that we can understand how best to target our resources. But we also need to understand the context by which the data that populate these sorts of dashboards are generated. And that's the real piece that I don't think that we're spending enough time trying to fix. So if you could advance to the next slide. I'm just going to show you a screenshot from one day, and actually this graph doesn't appear on the dashboard anymore, but it used to, and it was the daily case numbers being reported each day across the globe. And as you can see from this graph, there's one day that's not like the others. There was one day, and you can imagine on that day, when we got those case numbers, we thought, what's going on? Like, this is an error? Is something else happening? What is going on? And it wasn't until, you kind of parse, you look at the data and you realize it's all coming from one country, and then you look in the news and you realize what's happening, which is that this was a day where a single country decided to change its case definition. So one country's policy decisions can greatly change our understanding of how the pandemic is unfolding and what it means for the global community. And the truth is we don't have the standardized definitions so that all countries are finding and reporting cases in the same way. So what we have here is really a hodgepodge based on what countries decide to do. So this is one of the challenges when we talk about global surveillance, which is how do we actually get a meaningful common global picture of what's happening absent standards for how we collect these data, how hard we look for these data, and how we report them. If you go to the next slide. This is further complicated. So the case definition one is probably an easier problem to solve, but what underpins our abilities to find cases is a much harder thing that we also need to invest in. And that's countries have different capacities to go out and look for cases. This is a graph that's not up to date, but it was taken at a point in time showing test positivity from different countries. And as you can see, there's a huge range. And there are some countries, like Mexico's up here on the top, that had very high test positivity throughout the entire duration of the pandemic. And what that meant is that they were not doing a whole lot of testing. So the people who were getting tested were the people who were highly probable of having the SARS-CoV-2 infection that causes COVID-19. So that means that broad testing in the community, testing people who are asymptomatic, was largely not happening. And this is indeed true. When you look at different countries' policies and different countries' practices, you see a wide range in terms of what countries were doing. One of the things we found in looking at these data was that many countries were largely, throughout much of the pandemic, only testing travelers because travelers paid for the tests. So what that meant is the positive test results were largely coming from people who were from outside the country, probably lower risk because they're probably wealthy and traveling, and not necessarily then reflective of what was happening in country in terms of transmission. So if that's what we're rolling up into our national or a global surveillance picture, then we're not getting a real sense of what is happening within countries. So beware when you see analyses that say this country did better than this country based on the data that these countries reported, recognizing that the processes by which those data are generated are very, very different, and do not in any way conclude that that capacities may not be relevant to those analyses, because capacities are what countries use to not only go out and diagnose cases, but also to count deaths and to determine cause of death. And if we want to get a standardized picture, we need to make sure, we need to level the playing field and make sure all countries have the same capacities and equal probability of finding cases, finding deaths, determining cause of deaths, and being able to report them. Next slide. So that's just a very brief snip on the data side. There's so much more I could say about data improvements, but I want to save time for the discussion, so I'll just kind of pause there and then turn to the workforce, because I do think that sometimes we spend a lot of time talking about data as though it's an endpoint, as opposed to a tool, an information input to a process that's supposed to end with a public health action taken to make people safer. And what is needed is not just a data point, a 1 and a 0 that your computer generates, but people to gather the data, to analyze the data, to act upon the data, and then to take action depending on where the data points us. And there are many different types of workforce that really, I think, are essential for this work, but I'll just focus on one, and I'll talk about the epidemiology workforce. So what I'm showing here is a graph from the most recent version of the Global Health Security Index, which we published in the end of 2021. And this shows just a snapshot of the epidemiologic workforce. As clearly you can see, again, lots of heterogeneity across the globe in terms of how many epidemiologists per capita exist in countries. And I think it really speaks to the continued work to make sure we develop, train, and retain the epidemiologic workforce. And I put some emphasis on the retain part because I am deeply worried about that going forward. I am deeply worried. In the United States, it's colored in relatively dark compared to other countries, meaning we tend to have more epidemiologists per capita as compared to other countries. But if you've talked to anybody who's worked in public health departments, you have learned that there's been a hemorrhaging of qualified, experienced public health workers, in part because they're burnt out, they feel threatened, they feel like there's a better career path for them elsewhere. And this is likely not unique to the United States. We've seen this in many contexts, and so I think we really have to worry about the sustainability of these workforces and making sure we not only train them, but we also retain them. Next slide. I do think, though, that it's not just about training epidemiologists. It's not just training community health workers, which I frankly think is one area of deep deficiency, for which if we were going to put efforts into any one place, it would, in my view, it would probably be that. And Saad, to your point about health systems resilience, I think that's one key lesson from our work in health systems resilience about the importance and unmet needs in terms of shoring up the community health workforce. But it's not just about the technical skills. It's not just about putting people in these positions. It's also about training them and empowering them to make decisions and to act upon the information that they have at hand to say, we need to do something, and here's what we need to do based on my training, based on my experiences, based on what I'm seeing in the data. Again, data are not the end point. Data, they're the start of the process. They're the information we use to act. But what we have seen is really a lack of empowerment of the public health workforce to be able to act and to be able to act swiftly such that we respond to events that occur with the possibility that they could be worse than they might seem right now. And let me tell you, seeing the monkeypox, I'll just call it a debacle, play out in the United States on the heels of a COVID debacle where delays resulted in costs to threats to life, seeing that yet again play out in terms of our response to monkeypox, a virus for which we had more tools and frankly a better leg up than we did for COVID. I think we have to take a hard look at how we are training and empowering public health workers to act on situations such that we can get ahead of them instead of constantly looking backwards and leading sort of based on our retrospective understanding of what's happening. Next slide. I also think in addition to having the data and having the workforce, and obviously we can look at what's happening in events that are happening, but in the interim, we need to practice. We need to practice not just as a workforce with the plans that we have, but also as societies. And I have spent a lot of time thinking about how pandemic threats relates to other hazards in our life, and I spent a lot of time thinking about how it relates to how we think about fires. And what's clear is that when you have a recurring hazard, you don't just need the capacities to deal with them, you also need to practice what you do when it happens. And that is something where I think we are quite deficient, and there are, I think, more opportunities to practice. Prior to the pandemic, we did a study looking at how Taiwan conducted every single year mass vaccination exercises. They did it during the flu season. They did it so that they could boost uptake of flu vaccines among the most vulnerable, but they also did it so that they could practice what they would do in a pandemic. So not only could they test their systems and their personnel, but that the public would know where to go to get a vaccine so that in an emergency, it wouldn't feel like this weird thing that showed up out of nowhere, that it was the thing that you do, just like we do regular fire drills, so that when the alarms go off for real, we don't spend critical time trying to convince ourselves it's not really happening. We just act because it feels familiar. We rely on that muscle memory. And I think we need to do more of that in public health. Next slide. And then finally, I talked about this sustainment issue and the point that we can't just buy these single-use solutions every time we have an emergency. We can't just, take a whole lot of money, try to hire a whole lot of contract workers, and then as soon as the case numbers come down and the funding lapses, we let them all go, and then find ourselves scrambling when the next event happens. We have to sustain it. And this is, I have data here from the United States, but I think this is playing out in many, many places across the globe where we have that initial emergency response, and then we get tired and we move on to other priorities. And so this is just what public health preparedness looked like in the early, 2001, 2002, 2003. So 2001, some of you may be too young to remember, but the nation experienced a real shock in terms of the events of September 11th and a real commitment to never again make sure that we are unprepared for public health emergencies. And so there was a real increase in the amount of funding. And that was sustained for quite a while, and sort of the peak was around 2005, where I would say that was probably the time when our preparedness programs were the strongest. But then, if you go to the next slide, you'll see over time that commitment lapsed. And these data cut off before, I think, the worst of what we saw happen in public health, which was the economic downturn of 2008, where we know that there was a hemorrhaging of staff from health departments as state budgets basically contracted. And we saw this play out in other places around the world as well. 2008 represented a real, I think, departure point in terms of our preparedness programs, and it was also accelerated by the fact that national funding for these programs dried up at the same time that the economic crisis really strained local budgets. Next slide. This has consequences. This has real consequences. This boom and bust cycle has real consequences. And one of them was just before the pandemic, we interviewed health departments around the United States, asking them about their response to the measles outbreak that were happening before the pandemic. And one of the questions we asked them about was contact tracing, the extent to which they were employing contact tracing in responding to these measles outbreaks. If you don't know anything about measles, it is the clearest case for the need to use contact tracing. Measles is a highly transmissible virus, and wanting to put a large circle around it is really quite important. But what we found is that most health departments were not using contact tracing. They didn't have the workforce to do contact tracing. So when they had measles outbreaks, basically all they were doing was kind of putting up a notice saying, if you were in these places during these times, you may have been exposed to measles, call your healthcare provider. Great if you tell the healthcare provider what to say. Great if you actually have a healthcare provider to go to. And we certainly know that both of those situations are not necessarily true. So we saw a degradation in capacity just before the pandemic. And the consequences of that were very clear in the pandemic when we needed an emergency supplemental to suddenly hire all of these contract workers to do the work of contact tracing, which, if you know anything about contact tracing, is more like an art than a science, and really hard to just drop in place and have it be effective overnight. Next slide. So this is really my last content slide, which is to say, despite what you may have heard last night about the pandemic being over, I don't think that it is, but even if you think that the emergency of COVID is over, even if you think that 500 plus deaths a day is no longer an emergency, I don't, but if you do, you should not take from the ending of COVID that this is a once-in-a-century crisis and we have 99 more years of safety. The fact is, and Saad, you alluded to this in your opening remarks, the frequency with which we are having these sorts of events is increasing. There will be more. So these investments in surveillance and workforce and many, many, many other components of preparedness have to be viewed as fixed costs, maintaining an infrastructure that appropriately addresses the hazards of our times, which is infectious disease emergencies. So with that, thank you.
We can take a couple of clarifying questions.
Any clarifying questions? Okay. Yeah.
Thank you so much for the presentation. I worked on one of the first federal vaccination sites in Oakland, one of those mass vaccine sites, and we really were building stuff from scratch. I'm really wondering, are there other reasons as to why public health departments are notoriously underfunded for pandemic operations? Are they allocating budgets to other things? Are there other reasons for that?
So quick response. What we found, we did another study actually looking at mass vaccination capabilities at health departments, and one of the things we found is that health departments tended to work on building plans to hand out pills because they were working around an anthrax response scenario rather than a vaccination strategy scenario, which is a very, very different one, in part because of not enough resources to do those sorts of plans. But also, they had to do mass vaccination efforts in some part during the 2009 pandemic, and we very frequently heard from health departments, yeah, we used to have plans for 2009, but the person who worked on those plans is no longer here. So.
Yeah. Why is infectious disease frequency increasing, outbreaks?
Yeah, I mean, it's sort of the conditions of our times and the globe. We are much more connected than we ever were. So we do a lot more travel than we did, so that just gives the ability for people to mix in ways they didn't mix and to bring things with them. Also, we are encroaching into areas that put us in contact with pathogens that we may not have had contact with, and environmental drivers of pathogen emergence and spillover is increasing. And then we as a society are more vulnerable to these things. We have higher levels of chronic illness, vaccine coverage has lapsed, and so that just makes us more vulnerable to infectious diseases in general. And so that's why you're hearing about measles and polio and things that we didn't have to talk about 20 years ago quite as much again.
Thank you. So our next speaker is Dr. Wilmot James, and there are a lot of endearing qualities about him, and one being that I just noticed that he has a stopwatch in his phone, and I think that's certainly the academic side of his personality, not the politician side of his personality, because politicians don't know when to stop speaking. It's only the professors who are timed by other classes lining up outside. So, thanks.
Thank you very much indeed to Dr. Saad, and for the invitation from Yale University to speak here today. To tell you the truth, when I was in the South African Parliament, you're given 5 minutes to speak. Normally that means that they will shut it down after 5 minutes. There's something called the guillotine, which means you work on 100 words per minute and you practice it. So with that being said, let me speak about the subject of vaccines. So I can get the next slide, my disclaimer slide. No conflicts of interest, and just thanks to all of those individuals for being of assistance. The next slide, please. So there's a growing consensus in the world that we need to do three things. We need to focus on three areas of work. The first has to do with training and educating a new generation of individuals in public health and clinical medicine with high levels of expertise in a distributed way globally, and to network them. The second is to upscale surveillance, and we speak a lot about real-time surveillance. We actually don't have global systems of real-time surveillance. This is a 10-year-long project. Not easy to do. And the third is to have a decentralized system of vaccine manufacturing in the world. So I'm going to focus on that. And as you can see on the screen, there is now a commitment to developing vaccines within 100 days, which is breathtaking. The innovation during COVID-19 was breathtaking in terms of the speed of vaccine production and using new technology platforms. And after our experience now, we need to capture lessons learned from this period of vaccine development. We need to deliver options for the expansion of manufacturing capacity in low and middle income countries. And we need to establish a delivery and accountability plan. Those are the three elements. And I'd like just to share with you some thoughts about what's happening in Africa. Next slide, please. So what the framework is being set largely through CEPI and its plan to work towards shortening the time that it takes to produce vaccines to 100 days. And it really is quite incredible what has happened in the world of modern science today during COVID-19. This is an effort to even improve it, and they think it's possible with the right strategic focus, timing, funding, and so on. Next slide, please. So let me just say that, and you would know this, so I would just repeat this. Vaccines are among the greatest achievements of modern health science. It's one of the most effective public health interventions available. And to note, for those of you who follow this, immunization rates are falling in many countries. 1 in 5 children in Africa still do not receive all of the necessary and basic vaccines. And as of 2015, Africa accounted for 33% of the world cases of vaccine preventable diseases in children under 5. You can see the chart on the right-hand side indicating what that 33% amounts to cumulatively. Next slide, please. Just to note that governments in sub-Saharan Africa spend on average $73 per capita on healthcare, and that is less than 2% of the per capita spending by high-income governments and well below their national needs. The figure on the right-hand side provided by the World Bank, I'm sorry, it's not the best slide, but the bottom one you can see what the contrast is between the investment made by governments in sub-Saharan Africa compared to high-income countries. And that's per capita. That is not a crude figure. So you can see where the slack lies presently. Next slide, please. So it is estimated that every $1 spent on childhood immunizations in Africa returns $44 in economic benefits, just looking at the economic benefits side of it. And the 4 major vaccine-preventable diseases collectively cost the African region $13 billion each year. So there is the case. It saves lives, it extends lives, it saves money in terms of the impact in the longer term. It is a completely worthwhile intervention and investment from a moral point of view, from a life-saving point of view, and from an economic point of view. At the same time, Africa produces less than 1% of its vaccine needs. So there's the case to be made. It's a case to be presented to politicians. Next slide, please. Just demographically, 2030, Africa will have a working population of 1 billion people. And secondly, a really important point to emphasize, in my estimation, you've got 6 months. In fact, it's a small window of opportunity to introduce whole of government initiatives to support the establishment of an integrated, competitive, and cohesive vaccine manufacturing market for the African continent. COVID-19 was tragic, but COVID-19 illustrated the value of investing in preparedness, including in manufacturing of vaccines. And the picture on the right-hand side just tells you what the benefits are, in fact. Next slide, please. So, this particular illustration tells you what's going on in Africa presently in terms of vaccine-related activity. The data on the slide is 3 weeks old, and we update it regularly, but this is a fairly current picture, and there's one update I'd like to share with you. To note that the WHO has introduced a mRNA vaccine transfer technology hub. It's based in South Africa, in the city of Cape Town, where I am from, and it's identified 7 spokes as sites for vaccine manufacturing. That is hugely ambitious. We believe that South Africa and Senegal presently have the greatest potential and are focusing on that. The countries involved as targeted entities presently are Kenya, Rwanda, Senegal, South Africa, and Ghana as the sites. The second category are all the other industrial partnerships. Let me just say that presently there is no end-to-end vaccine manufacturing for human applications in Africa at all presently. What we have is fill and finish. There is a history of end-to-end vaccine manufacturing, starting off with R&D and ending up with a product for animals, but even the underinvestment in that has led to a degradation of that system, largely in South Africa, in a place called Onderstepoort, which is outside of Pretoria. When it comes to plants, that's another story for another occasion. So what has emerged are other industrial partnerships using non-mRNA platforms, and you can see what the list looks like there. Algeria, Morocco, South Africa, Egypt, Nigeria, Botswana, and Uganda, and what the list is of developments underway. An update is that Aspen Pharmacare, which is the biggest pharmaceutical company on the African continent, which had a license to fill and finish J&J, has signed a deal with the Serum Institute of India to produce 4 lines of vaccines, and we don't know what those lines are. We will discover. So what you see is a pharmaceutical company partnering up with the Serum Institute of India, which of course sees Africa as its market and will cultivate that. And all by way of saying that here the private sector is leading. It's not government that's leading on the initiatives. I just wanted to point out, you see down the line, Botswana, somebody called Patrick Soon-Shiong. So Patrick Soon-Shiong is a South African a physician. He's been in Los Angeles, made an enormous amount of money on an IP issue when it came to cancer, and is now one of the wealthiest people in the US. He owns the LA Times. And he has decided to invest in vaccine manufacturing, both in Botswana as well as South Africa. The Botswana operation is running together with Peter Hotez and the Baylor College of Medicine, and uses traditional means of producing vaccines. So the next slide, please. This is the amount of money that's flowing into Africa presently. It's 1.5 billion euros. With 300 million euros to be raised. It's a lot of money, but on the grander scheme of things, it's not that much. To note that the money is philanthropic, the money is bilateral, and the money is also multilateral, and that Africa itself is contributing very little to that. And to make this sustainable will require greater commitment on the part of African governments to in fact, invest in vaccine manufacturing. There are major challenges. The people are sort of mesmerized by mRNA. There's no way we can use mRNA platforms to produce vaccines in Africa as a whole. It has to be a combination a smart combination that focuses on Africa-specific diseases, both emerging ones and existing ones. To be sustainable, you need to do both. You need to produce for an African market for routine immunization, as well as pandemic scale up, scale down, dynamic response. And getting it done as a business requires a whole range of interventions that would make the de-risking of it possible, and so on. So all by way of saying, this is not straightforward. Next slide, please. So to meet the public health challenge, countries have organized on a national, regional, and continental level. In Africa, they emerged the Partnership for African Vaccine Manufacturing, which is an initiative of the AU, and at the multilateral and global level, the WHO Vaccine Technology Transfer Hubs involve the WHO and its partners. The next slide, please. We set up something called VacTask in response to a request by the South African government for a team of us to help them get in the business of manufacturing vaccines. So we set up VacTask, it's called. It's an independent advisory body to governments. It's working as a front runner for the Partnership for African Vaccine Manufacturing. It's supporting an effort to harmonize the regulatory environment. This is both product regulation and price regulation and financial regulation. But in this case, product regulation by way of the African Medicines Agency. There are 54 countries in Africa. If you want to make vaccines and need, approval of all 55, I mean, it's a nightmare, right? So there's an effort to have an AMA do that. This is not going to be straightforward, but we need that facility. And the purpose of VacTask, just finally, is to accelerate and expand Africa's R&D and manufacturing drives. Checking on my time. And therapies. Next slide, please. This is who we are. It's chaired by Jeremy Farrar, the Wellcome Trust. I co-chair it, and you can see it's a very distinguished list of individuals being part of VacTask. Next slide, please. What we've done to date is we conducted a first fact-finding mission to South Africa, and we're currently finalizing a report, a set of policy recommendations to be presented to the South African government. We've also hosted virtual meetings on the latest developments in pandemic response. The next slide, please. We are concerned and make recommendations about 4 things. First, to get procurement right. There needs to be harmony in procurement internally. You can't have the health department procure on the basis of price, and you don't talk to trade and industry. So there needs to be internal coordination, and then there has to be continental coordination. Secondly, the need for human capital investment in manufacturing skills. That is not the science part, which is in reasonable shape in South Africa, but in good manufacturing practice. Those skills are absent. You deal with them by importing those skills immediately, but you need to train a pipeline of people in that area. Third, a point I already made about regulation. The regulatory environment needs to be upgraded on a major scale, and there has to be also R&D infrastructure investment and in adjacent industries along the value chain as we move through. The slide on the right-hand side is just to illustrate and also to amplify the fact that the biggest investment that we can make is in human skill. That's the biggest one. And that takes a while, but that's something that's an important challenge. The next slide, please. You can do all of that, but if people don't trust vaccines and if they don't believe that it's a good thing to have, it's a kind of pointless exercise. Right now, Africa is sitting with a surplus of vaccines and they don't know what to do with it. So what's important is to have a model for vaccine take-up, and just very quickly. This is the environment in which we're operating. You can see that when it comes to trust in science, sub-Saharan Africa is the lowest and is declining. The next slide, please. When you look at trust in scientists, you can see the same thing. So also very low and declining. The next slide, please. Believe that sources base coronavirus-related decisions on scientific advice by region. You can see the level of distrust in the world. Also, sub-Saharan Africa is quite low. But the lowest is Russia and the Caucasus in Central Asia. Next slide, please. These are the categories of people that are the most trusted in the world, starting off with doctors and nurses and ending at the bottom, religious leaders. And the next slide, please. Okay, so that's the context in which we're operating. And so we started a project where we wanted to interview people who, at the late stage, come for vaccinations to understand what the barriers were. And this is unique in a sense, the study, because these are late stage wait and see people who come for vaccination, and we wanted to interview them. And we're running the project in South Africa and Zimbabwe. The next slide. This is a publication we made. The next slide, please. This is to the next slide. We just wanted to assess what the attitudes are to vaccine mandates. The next slide, please. The key thing there is that there was a high percentage of individuals who supported the use of vaccines in Zimbabwe. You had the normal pattern where high-income people had the least support and low-income people the most support. And the reason has very little to do with education or income, but to how many women in particular fall into the category of those who had the most support for vaccine mandates. And the important thing was, and as a discovery we found, if you can show the next slide, please, is that the individuals who were key to the answer around vaccine acceptance were mothers of children, even in deep rural Zimbabwe. We said they had the most questions about vaccine safety. You know, who tested it, where was it approved, and so on. And clearly, you can understand, it's kind of obvious that's would be the case. So just to say around drivers of vaccination, the trusted sources of information, the Ministry of Health, your main information methods for them were traditional media, and the most important influences had to do with who it was that loved them, basically. Those are the ones who made the real difference in terms of accepting vaccines. Next slide. I have 10 seconds left, I think. These are the main barriers to vaccination. As you can see, that more women had major concerns about the side effects than men. The relationship between wealth and education, and also internet use. You can see what the story is there. But let me just conclude by saying, with the next slide, that in the case of South Africa, what we found is an age grading in terms of what the impact was of both media and what the impact was of the different influences. And you can see that between 18 and 34, what the differences were. All by way of saying that the final slide, that what the world needs to do is develop a model for successful vaccine uptake, modulated by region, by country, and by culture, to introduce as part of pandemic preparedness for the next time, because we actually did not know what we were doing in terms of driving up vaccination rates. So, and so that's my concluding note, is that none of this matters unless there are evidence-based models for vaccine take-up built into the planning DNA for the next pandemic. And with that, thank you very much.
Thank you for an insightful talk. If there are any, again, clarifying questions, yeah. Stan.
The circumstances of very large vaccine companies are such that Merck, for example, can take a chance, make COVID vaccines, they don't work, they've lost tens of millions of dollars, and they move on. In the face of the incipient manufacturers in Africa, of which I think you had 7 sites, presumably they don't have the kind of deep pockets of a Merck. And presumably they're quite vulnerable to a particular vaccine they produce and manufacture and not having a market, and the whole enterprise could go under. So what is the intent of the global community to ensure a reasonable number of purchased vaccines so that that never happens?
So if I may, Stan, it's a wonderful question. If it doesn't quite fit into the clarifying category, is it okay if it's the first question I ask him after in the panel? Is that, you comfortable with that? Okay, thank you. Appreciate that. Okay, thank you.
All right.
I'm just trying to keep everyone on time. Thanks. So the next speaker is Dr. Beth Cameron. And yeah, your presentation.
Thanks. Hi, everybody. I think we go. Awesome. Well, I'm going to be speaking a little bit about the architecture that we need. And we've heard from both Wilmot and Jen about some of the tools that we need at the national level, at the regional level, and the global level. I'm going to try to get us up to the level of talking about the whole architecture we need for global health security and pandemic preparedness. I'm going to give you my bottom line up front on the first slide, which is we need to be faster, we need to have systems, and we need to practice every time. Jen alluded to this when she talked about the firehouse model. Nobody, when we think about a hurricane and hurricane preparedness, nobody looks at a community that is narrowly escaping a Category 4 hurricane and asks, why did we have so many sandbags? Or why did we evacuate? In fact, everyone's grateful that nothing happened. So we need to get in the mentality of overacting. And that means we have to have the systems ready to go, and we have to know exactly what we're doing every time. So next slide, please. So I just wanted to start with the consequences. These are the consequences, and I think it's pretty obvious to all of us who've been experiencing the pandemic. But this slide, 3 years ago when Jen, Wilmot, and I were talking about our last project together before the pandemic started, this was a pretty unimaginable slide. Next slide. And these are really the consequences. People lost their lives, the economy lost trillions, proliferation of disinformation and mistrust, government struggled. Next slide. Public health and other governmental officials and communities hesitated, but there were also a lot of incentives against acting fast. There were disincentives for acting fast. And what I mean by that is at the national level, when you don't have a system that everybody recognizes as the way that you're going to spring into action to respond to a public health emergency of international concern, you're making a decision on your own, for your own community, for your own government, even for your own region. And there are big consequences to getting it wrong if you don't have trust that the way that you're going to respond and act is a certain way every time. Next slide. So I'm going to really start by just defining what I mean by global health security, because it's a term we use a lot. We also use pandemic preparedness, we use health system strengthening. Global health security, in my mind, is being prepared to prevent, detect, and respond to public health emergencies that have high consequences, including public health emergencies of international concern, whether they're naturally occurring, accidentally caused, or deliberately caused. So in all of those cases, that's health security. It's a piece of the health system, but it's not the only piece. Next slide. I think it's important to actually look at the nesting, and it's hard to tell with the red here, but these are interlocking circles. And I see health security and the broader health system as not in conflict with one another, but sometimes those terms are defined that way. So I wanted to just sort of state my view on this topic up front, that preparing for pandemics is a piece of being prepared for an outbreak that might happen on a national or a regional basis, is a piece of our broader health system. So doctors, nurses, and access to care, which is absolutely vital for pandemic preparedness. And it's all a piece of our broader global health system. So all of this, in order to be prepared for a pandemic, we need to have systems that work at all of these levels. Next slide. So this is a slide that I drew from a document that Jen also referenced, which is the Global Health Security Index, a project that all three of us have worked on over the last couple of years. And this is a map that just shows preparedness by country. This was put together by the Economist Impact, by the Nuclear Threat Initiative, by the Johns Hopkins Center for Health Security, and now the Brown University is part of it too. It looked at over 100 questions, all WHO member states, and it asked what capacities are there in place to be prepared, to prevent, to detect, and respond, but it also looked at other capacities. So it looked at things that were particular to the ability of a country to be prepared for an outbreak or a public health emergency, like your laboratory system, your public health workforce, your ability to vaccinate your people. It also looked at things like numbers of doctors and nurses. It looked at trust in government. It looked at trust in science in the last version. And it looked at a country's ability to deal with crises in general. Next slide. And the bottom line is the average score taken together across all those countries was 38.9 out of 100. And that's just what countries could do. That doesn't necessarily mean that they even used those capacities. This tool was not intended to be predictive of how countries could do. It simply was meant to look at what countries would be able to do if they actually mustered the capacities that they had. Next slide. So I want to talk about architecture and what existed before COVID-19 in order to fill those preparedness gaps and be prepared to respond in the face of an emerging infectious disease threat like COVID-19. So drawing back to SARS, to the SARS epidemic in 2003, the International Health Regulations, which is essentially the agreement that World Health Organization member states have with one another, saying that they all plan to be prepared for a public health emergency of international concern, were updated. They were updated because the world recognized back in 2003, when SARS hit, that countries were not prepared to deal with a public health emergency. And the world gave a deadline of 2012 in order for all countries to be prepared. In that intervening time, what happened, because the IHRs were good, but imperfect in that they didn't define exactly what countries needed to do in order to be prepared. And when countries hit the 2012 mark, they either didn't know or they didn't know about each other's level of preparedness because there was no publication, no record of how prepared countries actually were. There was no red, yellow, green sort of stoplight mechanism. So following 2005 and then into 2012, when we recognized that most countries weren't actually going to hit the deadline that was put into place, the Ebola epidemic hit in 2014, and there was a lot of work already going on post-2012, this deadline that everyone missed. And countries decided they were going to put in place a scoring scheme to actually tell whether or not countries were prepared themselves and to be able to send people to each other's borders to actually look at how prepared they were. And the WHO Joint External Evaluation Tool was put into place to do that. And you can actually go online and look at how prepared countries are at the WHO website. We used a lot of these questions and added to those as the basis for the Global Health Security Index, which you can also go online and look at preparedness for every country. Around the same time, many governments, over 60 governments, launched something called the Global Health Security Agenda, which is a coalition of countries that decided we should meet regularly to talk about how prepared countries are for pandemics. During this period of time, this rough period of time during which H1N1, influenza happened, Ebola happened, SARS happened, Zika happened, countries were worried about influenza cases, H7N9 and H5N1, which were high consequence but weren't spreading as an epidemic or a pandemic. A lot happened. Budgets actually did increase for health security in some spaces, but not across our whole public health preparedness space. Looking at Jen's slide, totally agree with her. Nonetheless, when you look at that massive level of gap, 38.9 out of 100, when you look at the huge swath of work to be done on things like how do we make vaccines, how do we deliver them, how do we distribute them, how do we deal with vaccine update, funding and political will was wholly insufficient to be prepared. And we didn't have sort of recognized systems for how we would spring into action or triggers for those systems to work when an emerging infectious disease threat like COVID-19 came to call. Next slide. And so what resulted is that a lot had to be created from scratch, on the fly, in 2020. And this is an example of a lot of great work that happened during the pandemic, but it wasn't in existence beforehand. So as one key example, the ACT Accelerator, the Access to COVID-19 Tools Accelerator, was created in 2020 by governments, by non-governmental organizations, by international organizations like the WHO, like UNICEF, Wellcome Trust, the Gates Foundation, multiple governments, the Global Fund Against HIV, AIDS, TB, and Malaria, Gavi, the Vaccine Alliance, came together and said, how are we going to get tools like supplies, vaccines, tests, therapeutics, personal protective equipment, oxygen, to countries that don't have access to these things? So that was created on the fly during the pandemic, and it's a great example of what can be done. There's also a lot cropping up about how it could or maybe could be improved for the next pandemic. But this is a big open question. How will it be maintained? Which pieces of it will be maintained? What is the best way to keep this work going? And how do we fund that work? Regions like the African Union, and Wilmot talked a lot about some of the work to manufacture vaccines. There's also an African Union platform called AVAT that came online in order to distribute vaccines on the African continent. And so regions working with the global architecture, it was bumpy. There wasn't always agreement on how that would work, but these structures are in existence now, and we need to figure out as a world how best to maintain and move them forward. COVAX came into play, which is the vaccine platform piece of the ACT Accelerator. The G7, the world's largest economies, the G20, they all raised a lot of money, billions of dollars, in order to be able to fill some of these gaps. Finally, this year, the world agreed, the WTO agreed to waive intellectual property on COVID-19 related vaccines. And all of this there were presidential summits that the US government and others spurred into action. So a lot of work happened. But still, we landed in a place where millions of people died and we didn't have the systems that we needed. So this is the architecture as it exists. And what happens next slide, is really a big open question. So I'm going to talk for just a couple more minutes about where some of this might go and what recommendations there are, some things that have been done, some things that have not yet been done. But I want to make it really clear to everyone that this is an open question that still needs to be shaped with agreement around the world, and it's being actively discussed this week at the UN General Assembly. Next slide. So I highly recommend, if you haven't looked at some of the reports that have come out, I do think that the international experts that were commissioned to do a number of reports that I'll mention did a great job doing them, and there's some really great executive summaries that I think really put in, a lot of converging recommendations came out of this pandemic so far. So the G20 high-level independent panel looked primarily at financing. Do we have enough money to prepare for the next pandemic? Do we have enough money to be able to respond to the next pandemic? And where is it going to come from? What's the role of multilateral development banks like the World Bank? And also, do we need a new fund for pandemic preparedness? That is one recommendation that was acted on, I'm really happy to say, just a couple of weeks ago. The World Bank did launch a new fund for pandemic preparedness with over $1.4 billion. It's not enough. The vision is to have at least $10 billion a year for this fund, but it is a big step forward, and it is a recommendation that was shared by a number of international experts, and it's something that the US government and other partners around the world really pushed for. At the same time, the Independent Panel for Pandemic Preparedness and Response, the IPPR, under the leadership of Ellen Johnson Sirleaf, the former president of Liberia, and Helen Clark, the former Prime Minister of New Zealand, put out a report that focused a lot on leadership and governance for the next pandemic threat. They recommended a Global Health Threats Council, a set of world leaders that would meet regularly on pandemic threats, should come together, and that should have happened, in the last year. That recommendation has not yet been acted upon, so it's a piece of the architecture that is still out there in question. Wilmot alluded to the 100 Days mission. This is, in effect, a recommendation that came out of the United Kingdom's G7 presidency last year, to be able, on a very systematized basis, to look at all emerging potentially pandemic pathogens and develop platforms for vaccine candidates so that we can basically be ready to scale and produce, to do clinical trials and then scale and produce vaccines for almost any emerging potential pathogens. This is a really great playbook, but it is not yet funded, and there isn't yet a roadmap for how we're actually going to then produce those vaccines, and I think Wilmot did a great job of laying out some of the challenges there. The Lancet Commission published a large set of recommendations just last week, some of which converge with these other documents and some of which are also new. So there's a lot of work that's been done, not all of it's been acted on. Next slide. There's also a question about what we're going to do about accidental and deliberate biological events. all of the technologies that we need to be able to be prepared for the next pandemic threat are absolutely vital, but also we run the risk of inadvertently creating the catastrophe that we're trying to prevent if that technology is misused accidentally or on purpose. And so there's a movement to launch a new organization called the International Biosecurity and Biosafety Initiative for Science to bring together funders of research, the private sector, and governments in order to tackle this issue. And the Nuclear Threat Initiative is launching this effort this fall. So that's another piece of the architecture that has not yet been formed, but is starting to be built. Next slide. So when we look at the diagram on the right, these are my go-to pieces for the global health security architecture, the pandemic preparedness architecture that we need. When we look at financing, we've made some strides at preparedness financing with the launching of the new fund a couple of weeks ago. There's not yet agreement, though, on things like how do we get surge financing into place so that low-income countries can get in line to buy vaccines early on in the next pandemic. That's a big open question that still needs to be resolved in order to make the manufacturing architecture that Wilmot outlined actually work. Country capacity, huge number of gaps in country capacity, but increasing political will and interest, and probably a window with COVID-19 and now monkeypox to maintain interest at the highest levels of government in actually filling those gaps. That's critical that these two things are related to one another, that donors, that this new fund, and that countries look at their massive number of gaps in many cases, including in our own country, and prioritize which gaps to fill and how that will actually make them more prepared. So there's technical work, but also political work that needs to be done here. On access to medical countermeasures in a crisis, a lot happened that's really COVID-19 specific, with the ACT Accelerator being created, with COVAX being created, with regional organizations like AVAT being created, but none of that has been agreed on or concretized for other emerging pandemic threats. That's another big open question. On political will, there has not been agreement to create a new structure like a Global Health Threats Council. In the absence of that, there are questions about who will ring the alarm bell at the highest levels in the next 2020 scenario that we face. And then finally, accountability. So there has been a movement, one that the US government has supported among others, to amend the international health regulations to make them sharper, to make the reporting requirements more specific. And there's also an active negotiation in Geneva around the need for a pandemic instrument or treaty to bring some of this together and sort of, glue it. Next slide. So I'm just going to leave you with this. And what this is supposed to represent is that we have all the ingredients that we need. Maybe the only good thing that's come out of this pandemic is we now have all the tools, we have the ingredients, we have the thought leadership that we need in order to make the systems that are prepared, that will make us prepared for anything that comes our way. But now we really need the recipes and the practice so that the next time we actually are prepared and we can actually bake whatever it is that you want to bake that would taste the best to you. We need to be prepared to do it every single time using the tools that we now have. I'll stop there.
Any clarifying questions from Beth initially? Are you stretching or raising your hand?
Oh, sorry.
Okay, that's fine. Just checking. All right, so we can go to the panel now. So we'll come, as promised, we'll come to Dr. Stenberman's question, and that will be your questions. If you remember, you can start, and we can, or we can ask Dr. Berman to rephrase.
Well, first of all, to say it's a great question. So, vaccines are all about volume, and the African market is one market, and most companies would have to look at the bigger picture in terms of providing it. That's the first point. The second is that vaccines are made by industry, they're made by companies, they're not made by governments, and therefore there has to be collaboration with industry on this effort, and so government's role is to enable. Third is the point I made before. It has to be a combination, a smart combination of routine immunization, manufacturing and supply, together with the ability to scale up and scale down pandemic. So I'm making very general points, but that's required. And for it to be sustainable beyond the initial investments, African governments would have to put some money on the table for this issue, and that's going to take some political work.
Okay,
Can I
so,
two finger
yeah.
on that? Yeah, there's really not yet a roadmap for when you look at something like the 100 Days mission, which is incredibly ambitious, the ability to make a vaccine for any potentially pandemic threat within 100 days, and then what people colloquially call the 200-day mission, which is then the ability to scale that up and then produce it and distribute it. When you take that complexity and then look at a continent like Africa and plans for vaccine manufacturing, and you think, where should different platforms be produced? How can that couple with routine immunizations so that vaccines will actually be purchased and procured? It's complex, and I think it's so complex that some people are just sort of frozen. And what we need to do is actually start putting roadmaps out there, putting ideas on the table for how this architecture can be maintained. Do you agree with that?
I do agree with that, but also to say that right now the corporate sector is leading the effort.
Okay.
So on the African continent, Aspen Pharmacare is the biggest company. So it has corporate interests, and there is a need to de-risk when it comes to sort of local manufacturing sites. So we have to make sure that we have a proper private partnership with proper agreements around benefit sharing built into it.
So I think another thing, if I may add, and first disclaimer, I sit on the Gavi board, but this is my personal opinion, which is that one of Gavi's, the global, which was formerly called Gavi the Vaccine Alliance, it's now called Gavi the Vaccine Alliance. It was called Global Alliance for Vaccines and Immunizations. One of the mandates, one of the reasons why countries put money into that entity is its market shaping role. If there ever were any case for Gavi flexing its muscle, is to shape the market in sub-Saharan, actually Africa, not just sub-Saharan Africa, continent-wide market shaping in favor of sustaining manufacturing. Having said that, in order for the capacity to survive, it will have to be a market-based solution. Some players in that ecosystem, that's the very nature of markets. We have tried government-led manufacturing around the world. It rarely works. There are exceptions, but it rarely works. Truly, wholly nationalized vaccine manufacturing system. So on the one hand, I think Gavi has a role to play in this. On the other hand, it is through sort of nudging markets, shaping markets, not sort of encouraging 100% nationalized manufacturing. So I'll come to, sorry, you were going to say something?
No, just to say, which means we might get procurement right.
Yeah, absolutely. That's market shaping, essentially.
Yeah.
And so a couple of questions, and I'll have two versions of the same question from both of you, for Jennifer and Beth. So Jennifer, I'll start with you. What are two mistakes U.S. policymakers made in this pandemic?
Just two?
Just, well, top two.
Let me see how I can lump it to a big enough bin to catch a lot of stuff. I mean, I think Beth hit on it in terms of that acting fast and then acting given the possibility of the worst case scenario. And, you know, we saw this actually happened in COVID and it happened in monkeypox, same thing. One was, you know, testing was our critical failure. And the first one was marred by, the rollout of testing in COVID was marred by technical difficulties. But there was a period of time there where we didn't act on the urgency. We didn't think, this could get really bad and how can we scale to how badly it can be. Then we saw that play out in COVID, in monkeypox, where you know, we had the tests already rolled out. We didn't have to overcome that technical hurdle that was already there. But that infrastructure was really scaled to a much smaller event. It wasn't looking ahead to a more distributed community-wide event whereby you would need to have this testing more distributed. So I think that was the first one, was what Beth said, sort of failure to kind of think ahead, how bad could this be, and what do we need to start putting into place now, given the possibility of where this could go. I think the other thing was that we really need to take a hard look at our health system and make sure our responses are integrated into our health system, because that really is the first point of contact. But also, I think we need to take a look at how equipped our health systems are for these events, and really perhaps rethink healthcare models. This just-in-time, very lean organizations just don't work when there's an emergency. And unfortunately, there's lots of emergencies. It's not just COVID. I mean, I was telling a group of students earlier, we did a study just before the pandemic looking at hospitals in New York City and how ready they were for the 2017 flu season, which rivaled the 2009 pandemic in terms of volume. And they really, really struggled then. And that was, I think, an omen for how difficult things would be in COVID.
Yeah, so you're absolutely right. So building capacity, as both of you, or actually all three of you alluded to, after an emergency is like, recruiting firefighters after, your house starts burning. And so you don't call them at that time. So I'll ask you, Beth, what do you think were the two biggest mistakes that global policymakers made?
Yeah, well, I'll just say in 2020, I think, I'll just say that the US government was exiting the World Health Organization and the global stage around the time that the world, in my opinion, needed US leadership the most. And so I think that was a huge mistake. And I think that dogged the response for months and months and months. And probably still makes it harder for us when we are looking at how best to fix some of these architectural questions that I just put up on the screen. So that's number one. I think you can be frustrated with the global system. You can be rightly asking for the global system to do more. You can look at the United Nations and say, I want you to do better, but exiting only hurts people, including people in your own country. So I think that was a huge mistake. The second thing I'll say, and maybe I'll just bring the question up to the level of, what do we as policymakers in the United States and globally fail to do in every emerging infectious disease crisis that I've been a part of, and I'll include myself in this. I think that we fail to look at the worst case scenario and plan backwards from that. That doesn't mean that we act without any evidence or we put in place things that are factually incorrect. But it does mean that we need tools, back to some of the things that Jennifer said in her talk. We do need tools that are ready in the absence of information, in the absence of perfect evidence, and in the face of the uncertainty that we will always face at the beginning of a public health crisis. And so we need to be prepared for the absolute worst thing that can happen, for the multiple worst case scenarios, not just the thing that we think most likely will happen. I'll just say, I think public health officials have so little resources. They're trained to be able to and to want to respond to the thing that's most likely because that's all they can do. We have to resource public health appropriately and train the next generation of public health leaders to be thinking about decisions for the worst case scenarios. And that time that we lose in not preparing sets us back and puts us behind the curve every time.
I agree. So I couldn't agree more. I think it wasn't technology that failed us. So PCR was a technology that has been with us for decades. Testing and masks, the masks I'm wearing, this technology is pretty straightforward, and it was designed, actually even the best version of it was designed in 2009, 2010, et cetera. It was governance. And if we don't have the capacity to make effective decisions, I think we will continue to see these kinds of things. So I'll open up, sorry.
Yes, I just wanted to add, one of the things that I think one of the failures is we stumbled on the risk communication. And it's partly because
Stumbling on it.
part of it's the difficulty of a moving target, but there were some basic principles around risk communication that were simply not followed by many countries in the world. Inconsistent communication, changing the people speaking, and we stumbled in many respects. And so the public was also had to face disinformation and misinformation. We understand that, but in the middle of that, I think strategies for better risk communication really needs to be developed for the future.
Well, you're speaking to the choir, because some of us were jumping up and down in February and March. Here at Yale, we did our first national survey on February 9th, 2000, looking at the behavioral and communications response, looked at what were the sources of of information that were trusted, et cetera, and what should be the response before it was named COVID. We did our first national survey around vaccines on May 9th, 2020. And so you're absolutely right. And we thought as a global community that we need to bring the best science, and this is mainstream thinking, forward, and we need to insist on the rigor of vaccine development science, but not the rigor on vaccine communication science. And that was, a very sensible folks thought that it was just furrowing your brow and speaking on the primetime TV was sufficient, and that there were no principles, no evidence to be utilized in terms of how to effectively communicate. So you're absolutely right. And next time we better not do that. But monkeypox is not a good, sign for that. So I don't, I'm not that optimistic that this will not happen again. I think it's not. It's up to the next generation of public health leaders and scholars and implementers and policy developers to make sure that this is not an afterthought.
I think we also need people who are training in public health and people who are training in basic science to be cross-trained even more effectively. And what I mean by that is that we were developing new vaccine platforms that had never been used before, mRNA vaccine platforms, while we were trying to communicate to the public about how they should trust these vaccines. And so the scientific development was amazing and revolutionary, but that set us back even further with the trust in science communication, because we are not just talking about tools people were already nervous about in some segments of society. We were talking about brand new tools that hadn't actually been tested before. So I think figuring out how to have that kind of communication with the public around a new and uncertain science makes it even more complicated.
That's absolutely true. So we'll jump to questions from participants and audience, but we'll go to online questions first. So maybe, yes.
So I have two questions. I think this might be for Wilmot, related to vaccine manufacturing in those 7 countries that were kind of identified or something. What was why were they chosen? So that's maybe question one. The second question is, for those countries, are there plans for skill building to ensure sufficient human resources as well?
Excellent question. So the choice of countries, when it came to developing the spokes for the mRNA transport technology, was a selection made by the WHO. And that had to do with whether there was existing partners in those countries on various aspects. So Tunisia, for example, is very well positioned on the bioinformatics side, but it lacks others and so on. So that was the one set of criteria. The other had to do with what companies chose. So, so companies chose to site work in Kenya, which makes a lot of sense. Kenya has a lot of interest and experience in developing animal vaccines because of the animal health experience. South Africa probably has the longest reach. So part of it's just company choices. And so it's a combination of those things.
Any other question from?
Sure. Second question.
Can you say the name of who's asking?
Sure. And this, Jennifer, this question comes from Dr. Christina Towers-Slagle, who you met earlier today. She was appreciative of your note when you noted that one thing you would invest in was community health workers. So could you expound on that a little bit more? Why and how you feel that would help prepare for the next step?
Yeah, I mean, I think the community health workers have the potential to touch on many areas that we saw deficiencies in. One is clearly on health services and reaching people and continuing to provide not just care for the pandemic, specific care, but also all the other care that has to happen during the pandemic that doesn't stop. And I think we cannot put blinders on and only focus on a virus and not consider the whole health needs of communities. And that's, I think, a lesson that we learn every time there's an emergency. So community health workers, I think, are important for supplementing the care and extending care and providing care where communities are. But they also potentially help on the risk communication side. And, I think that was clearly something that we had a hard time doing. We didn't really have plans for, as Beth and Wilman and Saad said, talking about, we were great on the technology, but we didn't think about how we were going to roll it out and get people to want to take it. I will just tell you anecdotally, in the last 2 years, I have talked to hundreds and hundreds of people about COVID vaccines, and one of the key commonalities that I have found in those conversations when people are asking me questions and they sort of suggest that, trust, not sure who to trust may be an issue, they commonly don't have a healthcare provider in their lives. And so making sure we have people who are in people's lives, not just suddenly they show up in the midst of a pandemic, but they're in people's lives day to day, dealing with the various medical issues that could arise throughout someone's lifespan, then to also be able to broker conversations about vaccines, to be able to connect people to the services they need, and to be able to get connected. That sort of bottom-up approach, I think, is really important. So.
Yeah, absolutely. And even in your work, you talked about, Wilmot, that healthcare providers were the most trusted source of vaccine information. We've been finding, and it's, a lot of those work for the last 22 years consistently shows, irrespective of geography, the top most trusted source of vaccine information is a healthcare provider. And so that means access to a healthcare provider, but also, and again, one of the more lost opportunity in this country was, and beyond, frankly, as well, was a lack of a national CME program to train healthcare providers on evidence-based communications methods. And it exists. So at Yale, we created a CME. It's the most subscribed CME program. And the second most was a third of the of attendance, where people took it for certification, and that was state's mandatory, CME. And so there is a demand out there, but you were saying something else, I guess, as well.
No, I was going to say there's enormous variation. So it's healthcare workers, and obviously come first as a category. But the most trusted institution in Tunisia is the military.
Yeah.
The most trusted institution in the Congo is the Catholic Church. And the most trusted institution in South Africa is the President of South Africa. It's enormous variation about how trust works. Also, just to quickly answer the second part of that question that I failed to answer, is that when it comes to vaccine manufacturing, you're talking about an ecosystem you build around that, including relations with universities where most of your scientists are located. And then, as I pointed out, where the gap is the training in good manufacturing practice in making vaccines. This is the pharma side and the pharmacological side. That's where the gap is. And what's required is a scholarships fund to train people in that area. That takes a little while. So in the meantime, there's a need to import skills.
So Beth, I'll ask the next question from you. So when you talk to folks and public health leaders, specifically around the world, especially in low and middle income countries, not everyone is on board with the term biosecurity and biopreparedness. And even, whatever version of the word security is. So you sometimes get pushback from there. So any thoughts on framing our collective preparedness in those terms?
Yeah, and I think one thing I'll say is that it depends on who you talk to. So if you're talking to public health officials, sometimes there is concern with using that term. If you're talking to leaders in ministries of foreign affairs or in national governments at the highest levels, there's less concern. And that, again, that's a broad generalization, and it really depends on the country that you're in and the people that you're talking to. So I always start by defining what I mean by health security, because it makes it clear that I'm talking not only about security, as in national security or national defense. I'm talking about security for people, our public security and our public safety. So I like the term health security. I think that it's an important term. I think that we should continue to use it, but I think it has to be framed in the context of the broader health system. And I think that you just made an outstanding point in the conversation about healthcare workers and community health. If we don't actually have a strong healthcare system, we know that we're not going to have global health security. So you have to look at those two things together. But I do think that there is a touchiness amongst some in the health community to using the security terminology. One challenge I find with that, wherever you sit on that debate, is that when we have a crisis like COVID-19, pretty quickly things move from ministries of health as spokespeople up to the level of government, and that's always going to happen. You're going to have prime ministers and presidents speaking, you're going to have ministries of foreign affairs involved, and so you have to recognize that security is part of the equation. It is, it absolutely is, and so the question is, how do we work together to solve this challenge as a public health and a national and international security issue, because it is. And I think COVID-19 clearly showed that. And so that is another reason why I'm really in favor of cross-training people who go into political sciences and end up in pandemic preparedness, and people who go into public health and end up in pandemic preparedness, so they don't meet for the first time in the Situation Room at the White House.
And maybe can I just add to that, because I heard there was a debate at one point, and particularly when we looked at the rollout of vaccines globally and the stark disparities that we saw, there was this kind of rising debate that this was as a result of our securitization of our health threat. The idea being that countries wanting to preserve their own security were therefore hoarding vaccines and not giving it to others, and that had we not kind of viewed the crisis through the security lens, that perhaps that wouldn't exist. I will tell you, from working in this field for more than 20 years, I kind of fundamentally reject that interpretation, because let me tell you, the hoarding has persisted long before we ever started using the word health security. We saw it happen exactly in 2009. Before that was really a term that was thrown around. Countries in emergencies, particularly when they're unprepared, and particularly when we don't have global mechanisms for sharing, will do just what we saw them do. And every single tabletop exercise we've been in with leaders, they tend to have that tendency. So I don't think it's the securitization. I think it is the false understanding of what it means to be secure. And being secure means not just looking inward, but also seeing how events that happen outside affect what happens inward.
So I'll take the next few questions towards the end of
I
this.
just
Yeah,
want
go
to
ahead.
make one little point. It's just, there are lots of Ebola samples that are unaccounted for. So the question of laboratory biosecurity and the transportation of pathogens security is of the greatest importance, and we need to upscale that. That's all I'll say. To those who talk about biosecurity not being an important component of our overall effort.
Remember, all the disaster movies start with a scientist warning about exactly this kind of stuff. Lots of Ebola.
You can make agents from scratch, and there's very little regulation around the world
that is
on
true.
this topic. And so given that, anyone who goes into public health needs to be thinking about diseases that are propagated intentionally or accidentally. That doesn't mean conspiracy theory. It means this is a fact that you have to deal with, and that means public health and security have to work together. You will work with the security community if you're not already, and so getting comfortable with that is important.
Yeah, so Maddie, if you have a question.
Hi, Beth, this question is for you. I'm wondering if you have in mind a country or an entity that has really put together the architecture and the pieces that you're talking about. What is a model, or a model that we could work toward? Are there any?
It's a great question. I think we should, a couple of us should answer that question. I don't have one country. The model that I think fundamentally will work has to rely on countries being prepared, so filling the priority gaps that they've identified through an evaluation that either they've done or an external organization has done. At the next layer, we need to have strong regional institutions. I think the African Union is a great example of a regional institution that flexed in a crisis where they weren't able to get access. They were able to build internal tools for a continent of over 50 countries. That kind of regional strength is important because not every country is going to be able to have everything. And at the global level, we have to have institutions that can help develop and invest in vaccines, deliver tests and treatments to those that can't get them. So it has to be at all three levels. I don't think any one country can do it. I do think that there are some countries, when you look at just how well they work internally across sectors, that are doing a great job. One of the reasons that the Global Health Security Agenda was launched with a number of countries, including Finland, in 2014 is because the time, and I believe this is still true, the government of Finland had a very strong interagency mentality where the ministries of health, defense, foreign affairs, and agriculture worked really closely together. I think that is a model that we need in order to be prepared for any kind of health threat within individual governments. It's also true for the US government. I know it's not easy to see from the outside, but there is constant communication. We just have a slightly bigger system to herd the cats.
So my last, sorry, Wilma,
I was gonna just add one thing. We need much better leadership on this issue. The leaders are elected, so you get what you get. And there's no, resume to evaluate. But you need below presidents, you need a very strong cadre of public health professionals that provide stability in terms of leadership on the civil service front.
Okay, so one last question from you.
I'm just curious to see what role can big, wealthy and research-grounded universities such as Yale and Brown play on the global stage for pandemic preparedness?
So that's a perfect question for you.
Yeah. I think a few roles, and they're what universities do. We conduct research. We try to gather the evidence to answer the most pressing questions. We also educate, we train the next generation of leaders to make sure that we have in place exactly what Wilma talks about. And then one thing that I think has, COVID has, I think, changed how universities operate, and I hope that this is a legacy of COVID, which is that we have to do more translational work. We have to do more work to take the evidence and make sure it gets to the people who are making decisions and continue to push on them to make the right decisions based on the evidence. That piece, I think there will always be room for independent, credible voices to both evaluate what governments are saying, as well as continue to educate not just people in our programs, but the general public for how they can protect themselves. And so I think that translational piece will be hopefully a bigger piece of the portfolio of what universities do.
Yeah, no, I think that's a good place to end. I resisted rephrasing that question as what can Brown do for you? But thank you all for being here, for your insightful responses, and thank you for you all for being here and for your questions, both within this room and online. So with that, we end this panel. Thank you.